Good evening, everyone. If I will be speaking about only mid-substance tear in open physis. So why there is so much fuss about mid-substance tear in pediatric patient? Traditionally, these injuries are considered to be rare injuries, but nowadays with active sports participation in a pediatric patient, the number of mid-substance tear, ACL tear are increasing rapidly. There is almost 400% increase in ACL injury over the last decade. So why there is a dramatic increase in ACL tears in pediatric patients? Because of increased competitive athletic activity among these adolescents, early sports specialization, increased awareness of these injuries among the clinicians and parents, and year-round training and competition. If you see, any adult athlete will play for certain seasons, but these kids play for year-round, so there are higher chance of injury. Also, we as parents are emphasizing skill development rather than fitness in these children, putting more stress on the ligaments and bones, causing more ligamentous injury in these patients. There are certain intrinsic factors and extrinsic factors in this age group. Intrinsic factors being hormonal, biomechanical, and anatomical. Hormonal factors more relevant in female pediatric population, like estrogen receptors present on the ACL. Biomechanical factors like deceleration and landing maneuvers affected by posture, alignment, and quadriceps activation. Certain anatomical factors like increased anteversion of the femoral neck, valgus angle or increased Q angle, and decreased intercondylar width in this population leads to increased chances of intersubstance tear. Extrinsic factor like competitive sports, specifically football, weather conditions like rainy conditions and footwear surface interaction. As I told, females have got more incidence as compared to males in this population, even with the same sport and in the same school, according to studies. There is always some dilemma to diagnose interstitial ACL tear in this patient population. They usually present with acute traumatic hemarthrosis, which is also present in patellar dislocation. So you need to rule out what it is, because of the ligamentous laxity present in this patient population. It is difficult to conclude whether the pivot shift test or Lashman test is because of ligamentous laxity or because of the injury. Also, to interpret this test like Lashman, anterior drawer, and pivot shift test in pediatric population is difficult because of the compliance of the kids. Also, it is very important clinically to see the malalignment and limb length discrepancy, because it may be the reason for ACL tear in this population. We do routinely standard radiographic evaluation, anteroposterior lateral notch and merchant fuse, to rule out other common causes like ACL avulsion injury, Sigon fracture to see which is a telltale sign of ACL injury, long leg film to see malalignment. MRI is not as good as adult ACL tear in pediatric population. It's difficult to interpret, but still it is a very good tool. And it allows evaluation of other concomitant injury like meniscal injury and chondral injury. Peculiar to this population, we need to evaluate the skeletal age for this patient, because the treatment algorithm depends on the skeletal age. Chronological age is not that useful as compared to skeletal age, because sometimes we see a patient who is 16-year-old looking like a 10-year-old boy, and sometimes a 12-year boy with mustache. So chronological age is not useful. You need to use posterior anterior radiograph of left hand. You may take a help of pediatrician, which we do, Tanner staging, age at menarche, and look for the markers of maturity and growth spurt. So why these tears in children are different? See, the kids are not miniature adults. So there are a lot of differences like ligamentous laxity, physis is there, neuromuscular incoordination is there. Also, there are studies which suggest that if you repair or reconstruct this ACL, there are high chance of re-tear in tunes of 5 to 25% in this patient population. This high failure rate is maybe because of graft choice, like allograft or small diameter of the graft, which we use for this patient population. Early resumption of sports activities, because kids are difficult to contain. Physiotherapy compliance is always doubtful in pediatric population. Faulty surgical technique and skeletal development. Most of this tear usually occur in just prepubertal phase at the growth spurt. So it has something to do with the high failure rate. If you see the lower extremity growth, the distal femoral physis contributes to around 10 millimeter per year of growth, and proximal tibial physis around 6 millimeter per year of growth, contributing to almost 42 centimeter in boys and 38 centimeter in girls of growth from birth to maturity. So whenever we do ACL reconstruction, there is always a concern of physeal injury causing damage to the physis, leading to limb length discrepancy, angular deformity, and recurvatum. So that is the main concern when we operate these patients. So we can tackle this thing with non-operative treatment. It is taken as ABC, that is activity modification. Doubtful in children, we cannot contain them, as I told you. Bracing, which is compliance related, still doubtful, and continued rehabilitation. So the problems with non-operative management in this patient population is continued instability, higher incidence of meniscal and chondral damage with non-operative management, and inability to return to sport with the same level of skill sets. So this paper by John McCarroll, and there are several other papers which suggest that the bracing rehab is not the way to go for a pediatric population interstitial ACL tear. They studied almost 40 patients, almost 50% patients with conservative management were not able to pursue sport at the same level, and they faced instability as compared to almost 100% patients, operated patients returned to sport, but there were 2 patients who had re-injury. This is a common question. Traditionally, all my colleagues or my seniors used to say that we should wait till the patient is mature and then we'll operate the patient. So should we wait till the maturity? The answer is no. There are studies from Henry and Julian and other people that if we wait for prolonged period, there are high chances of meniscal damage and chondral damage. So ACL tear per se may or may not lead to osteoarthritis, but these are secondary changes which will definitely lead to osteoarthritis in this patient population down the line, say 20 years. There is increased meniscal or chondral injury, 6% per month of surgical delay. So you need to balance certain things like chondral damage and risk of growth arrest when deciding the management for this patient. So still, this is very gray zone, and it is very difficult to decide what to do for this patient, and there is no clear-cut consensus. So for these patients, before venturing into surgical management, we must assess the emotional maturity of the patient and family, because they need to stick to strict rehabilitation protocol, and assess the angular deformity, because the valgus deformity will lead to ACL rupture. All these things are very important because there is high risk of re-rupture of ACL in this population. So you need to consider these 2 things before venturing into surgical treatment. So now, what are the surgical options for these patients? There are certain physeal sparing and certain transphyseal surgeries. The first one on the left side is modified Macintosh or Micheli-Coccus technique, in which we take ITB and reroute it. So it is usually advised for Tanner stage 1 and 2, and if there is skeletal growth remaining of more than 6 years. The second one is Anderson's technique, all-if physeal technique. So you drill a tunnel in the femoral physis and tibial physis. So this is physeal sparing technique. It is used when the skeletal growth is in tune of 3 to 6 years age of remaining. And third one is partial transphyseal. So transphyseal through the tibia and all-if physeal through the femoral tunnel. It is generally used if there is 1 to 3 years of skeletal growth remaining. And the last one is the patient who are at the end of the maturity or near the maturity. So we can do them like adult type of reconstruction. It's very important to avoid physeal damage in these patients, which is the crux of surgery in these patients. So drill should be less than 7% of physis. We should use soft tissue across the physis, soft tissue graft, not the bone patellar bone tendon. The drill hole should be medial, distal, and vertical, but it has also got downsides that if we put a more medial tunnel, it will be oblique and will damage physis more. If we put vertical tunnel in the femur, it will cause instability. So graft choices are usually ITB, hamstring, or quadriceps tendon. So coming to the first technique, that is physeal sparing combined intra and extra-articular reconstruction, popularized by Coccus and Micheli. So what we do in this technique, we use an ITB graft around 15 centimeter. We whip stitch the proximal part and reroute over the top of the femur and stitch it to the lateral periosteum of the femur that constitute the extra-articular part, pass it through the notch below the intermeniscal ligament and tie it over the post or the metaphysis that constitute the intra-articular. The benefits are it does not involve any drilling of any tunnel. Even it does not burn any bridges because you have got your graft choices remaining, and you can, if it fails, you can do ACL reconstruction like a virgin knee. But the downside is that it is non-anatomical, but the results are very good in terms of 96% of patients return to sports activity without any complication. Second one is Anderson's intraepiphyseal reconstruction. It's fluoroscopic guided technique. We make drill holes in epiphysis of the femur and tibia, and we use soft tissue graft. So for that, you need to put your C-arm on the opposite side of the operative leg. You need to get a proper lateral view. Sorry for this view. So you use a zig with 90 degree of angle for the femur. We get around 30 to 35 degrees of tunnel on the femoral side. It's very difficult for the tibial tunnel because it's very small portion. We get around, and you need to use angle guide of 40 to 45 degrees for tibia, and the tunnel size around 16 to 20 millimeter. But it is anatomical, and the benefits being it restores the footprint, so better functional result, no injury to the physis, cartilage damage is minimized, and good to exceptional functional results are there. Risk being, if the technique is faulty, you may damage the physis. A rupture of reconstructed ACL may occur, and soft tissue formation or arthropfibrosis will occur. Transphyseal may be, as I said, it may be partial or complete. It is usually used in patients who are nearing maturity. The result-wise, all the techniques, there is no gold standard as such. All the techniques have equivalent result. More than 90% of patient of 14 years age or lesser return to sport with same skill level. As we are lacking the understanding of a typical algorithm for these patients, there is a very good upcoming study called as Pluto, that is Pediatric ACL Understanding Treatment Options. It is a cohort study going on in across 10 hospitals in US, and evaluating safety and effectiveness of each treatment strategy for pediatric age group. So hopefully it will throw some light on the management of this patient. So take home message is that the ACL tears, that is interstitial tears in this patient population is on rise. Sports are risk factors. You need to balance the growth disturbance versus development of arthritis and higher failure rate. Early reconstruction decreases the chances of damage, and I will recommend that you should have a consistent age-based treatment algorithm for this kind of patients. Thank you.